Good afternoon to everyone joining us for the fourth webinar in our Experts on Air series on closed-loop ventilation. My name is Caroline Brown from Hamilton Medical, and I'm delighted to welcome our two experts, Professor Giorgio Iotti from Italy and Professor Marco Maggiorini from Switzerland. Today, they're going to talk about the use of closed-loop ventilation in brain injury patients. I'm sure most of you already know how this works by now, but if you're watching for the first time, your cameras and microphones are switched off, but you can use the Q&A function to ask all your questions. The session is being recorded and you'll receive a link to the recording by email early next week. And now it's time for me to hand over to Marco Maggiorini in the interviewer seat. Marco, the stage is yours.
Thank you very much, Caroline. It's a big pleasure to be the chair of this session and to have as a speaker in this time Giorgio Iotti, who is a very well-known intensivist and anesthesiology, former chair of the Institute Policlinico San Matteo in Pavia, and a member of the University of Pavia. Giorgio is a fantastic clinician, working at the bedside for years and years and teaching a lot of residents. And he is also a researcher. Since the 80s, his focus of the research was mechanical ventilation. He was involved in physiology and pathophysiology of acute respiratory failure. He studied mechanical ventilation, pressure support ventilation was one of his topics. And during the last, let's say, 20 years or he was involved in automation, mechanical ventilation. So the ideal person to give is this talk about automated mechanical ventilation in brain injury. Giorgio, you're the word.
Thank you very much, Marco, for your presentation. It's thank you very much to Hamilton Medical for this invitation. It's a pleasure to have you as a moderator on this topic. So thank you. You said a lot about me, what I've done. I can add that I had very strong co-workers in neuro ICU. This was not my main interest, but my co-workers have I have learned a lot from my co-workers, and I hope this will be really useful for the message that I want to transmit today.
Okay. Before we start with your talk, we have two questions to be addressed to the audience. The first question, poll question, is, you see it now on your screen. Is brain protective ventilation in trauma brain injury a challenge? So please give your answer, whether you think it is you strongly agree, whether you agree or you are neutral, or you disagree, or you say, okay, it's no problem at all. Please give your answer. Giorgio, for you, it is a challenge. What do you think?
I don't want to anticipate and to influence the audience, but you will, yes, a bit, not always, really not always. I will discuss about also a combination of conditions. There is one thing that facilitates a lot: sedation for me, brain injury.
We see the results now of the question. So it's interesting to see that most of the people agree that it is a challenge. So we will be
Nobody
excited.
Strongly disagrees.
No, exactly. So we are excited to listen to your job, but before to your talk, sorry. But before we start, the second poll questions, please.
Okay,
so again,
how frequently do you use INTELLiVENT ASV in acute brain injury, if INTELLiVENT is available for you?
I think it's not a question that I have to ask you, Giorgio, because you are a user of INTELLiVENT ASV since many years. Otherwise, we would have invited you to give this talk.
And I am also happy that I know that my past co-workers are still using or are using even more. Yes.
So I used it as also very much. And I introduced it in my ICU at the University Hospital in Zurich many years ago. So here we have the results of this. So it's quite interesting. You have 24% that don't use INTELLiVENT ASV. So it's a new challenge to convince them, maybe if they have it, to use it for the future. But also there are quite several, or like 50% of the audience that is using or has some experience with the use of INTELLiVENT ASV in brain injury. So Giorgio, the floor is yours, and we are excited to listen to your talk. Thank you.
Thank you very much. So closed-loop ventilation in brain injury. I will start discussing which are the solid rules, what is evident, is much recommended, and maybe something more. I will refer a lot to this very recent paper in Current Opinion of Critical Care 2023, and the main message is highlighted here, which are the blood gas targets. Simply keep normal and stable, normal and stable. Interestingly, there are not only the more classic recommendations for CO2, but also recommendation for oxygenation. For the control of CO2, the target is the 40 millimeters of mercury of arterial CO2, avoiding hypocarbia, avoiding hypercapnia, defined at least as less than 30, more than 40, more than 50, just to avoid possible cerebral vasoconstriction and consequent ischemia, as well as vasodilation due to hypercapnia and possible increase in intracranial pressure. Recommendation is to avoid extreme fluctuation. So this is very classic. A little bit newer is to pay also much attention to oxygenation, not only for hypoxemia, but also for hyperoxia. And you can see that the recommended target is relatively strict, around 100 millimeters of mercury of PaO2 between 80 and 120. So these are targets that are not the targets of ARDS. It's really a target of normality of oxygenation. As for the importance of avoiding hypocapnia and hyperventilation, this is probably the first very important randomized study that shows that in the group submitted to hyperventilation, the outcome at 3-6 months was worse, although on average the control of intracranial pressure was the same. However, in the group with hyperventilation, you can see that there was some more variability. As for hypercapnia, the relationship between bad control of CO2, increase of CO2, and mortality is evident. Interestingly, it is not just a matter of CO2, but also of pH, because if a group of compensated hypercapnia in the study is considered, the effect, there is no more effect on increased mortality. So there are two different categories of hypercapnic patients, and the bad one, of course, is the hypercapnic acidosis. As for oxygen, the results are recent, and come mainly from studies for recovery after cardiac arrest. In this very large study performed in USA in out-of-hospital cardiac arrest, it has been found this U or J shape relationship between oxygenation after recovery for cardiac arrest and mortality. And as you can see, there is not only the obvious effect of mortality of hypoxia, but also the one associated with hyperoxia. These results have been confirming the different casuistics in Europe, in which the researchers studied the relationship between oxygenation during periods of targeted normothermia or targeted hypothermia and 6 months mortality. And here again, you can see the U shape, obvious association of mortality with hypoxemia, but also for hyperoxia, with thresholds that have been found between 70 millimeters of mercury and 200 millimeters of mercury. So these are the classic recommendation. Then we may wonder, is there anything else? For instance, discussion about these two relatively recent papers on short-term moderate hypocapnia. These two studies found that finally there should be no great reason to beware of a short period of hyperventilation. The comment on of these experts on these papers are much caution. They underline that in any case, all efforts should be directed to avoid hypocapnia, especially in the first 24 hours after the start of brain injury. But hyperventilation could be used for a short period of time when ICP is not controlled as a bridge pending definite solution. So with very good reasons, it can be considered, especially, but with much caution, with brain oxygenation monitoring. So with the understanding of what is happening. The other way around, short-term moderate hypercapnia. Even here, there is some proposal, some heretic proposal. This is an experience of therapeutic hypercapnia for prevention of secondary ischemia after severe subarachnoid hemorrhage. So the patient were submitted to 2 hours of hypoventilation. Here you can see the rise in CO2 to an average of 55 millimeters of mercury at near infrared spectroscopy. There is a rise and apparently an advantage in brain oxygenation that was associated with was due to a specific increase of the perfusion of the brain perfusion, with the peak at 45 minutes. Of course, making such games is at high risk of increasing the intracranial pressure. You can see that in this experience, it did not increase, but this was due to the fact that all these patients had a ventricular drain.
Giorgio, sorry, just to interrupt, we've had to remove your face because of the internet connection. So the presentation's still running, but your face is not showing, just so you know.
Okay. So which the message of these experts is that in particular cases, even short-term hyperventilation or hypoventilation can be considered, but in an appropriate context and with appropriate monitoring. So how to achieve these results with which settings, which limits for ventilation. So as you can see here, the recommendations are the same, finally the same as the one for protective ventilation. So plateau pressure less than 30, tidal volume of 6 in ARDS, not higher than 8 in ml per kilogram in non-ARDS, driving pressure less than 15. But obviously in brain injury, much caution should be applied. It's not only a matter of limit, but there is one big reason, one more important reason. So in any case, must consider the risk of increase in the ICP due to ventilation. It's nice to check here the recommendation, check the dead space, avoid for tidal volume in order to make tidal ventilation as much efficient as possible. So, which means not using HME filters, maximum reduction of the technical dead space. This will help to achieve a good control of CO2 with the minimum ventilation. Of course, there are cases in which, in order to control, to have good control of CO2, it will be necessary to increase the respiratory rate. Compensation by increasing the respiratory rate is not completely free of risk, because respiratory rate is one of the components of the today famous mechanical power. We know that the mechanical power, high mechanical power, is associated with increased mortality. However, rate of respiratory rate on lung damage is probably just 1/4 of the weight of the driving pressure. So there is a lot of possibility to play with safely play with respiratory rate. What about oxygenation? I already mentioned these relatively strict targets of PaO2, by which we can work with oxygen concentration in the ventilator. And then the big question is PEEP. Obviously, with PEEP, the approach is totally different depending on whether there is an underlying lung damage or not. If there is no lung damage, the appropriate indication is, while if there is a coexisting lung damage, the matter is much more complex. In my opinion, for sure, invasive intracranial pressure monitor is necessary, and it must be supplemented by non-invasive measurements like transcranial Doppler, optic shin nerve, ultrasound, and more. PEEP titration must be individual, very accurate. In my opinion, the more appropriate protocol would be an ascending approach, which, in my opinion, is a lighter approach rather than make a big step and then coming down. It's important for sure to avoid hyperinflation and to pay much attention to the principles of hemodynamics preservation. But this is general principles of neuro ICU. So how much challenging in the poll? Many participants have answered that it may be not not so easy. So in my opinion, the ventilator, in my opinion, there is one favoring factor that is sedation. Sedation is an important component of the treatment of severe brain injury, and for sure this facilitates a lot the ventilation, because on one side strong control of ventilation is needed. On the other side, the interaction, there's not much interaction with the activity of the patient. So keeping full control is easier. As for the settings, it depends, as I discussed much on the lung function, whether it is good. It's, of course, it's management is much easier if the lung is damaged, and it sometimes frequency is damaged due to associations or crossing of the disease. So the point is, our point today is may INTELLiVENT ASV facilitate this continuous strict control of carbon dioxide and oxygen targets, or even these well-controlled short periods of moderate hypocapnia or hypercapnia, if they are indicated, may help to achieve combined brain and lung protection. I make an example. It's a case that I had a chance to observe, a case of 80 hours of ventilation in INTELLiVENT, a relatively easy case because the lung function was good, and patient was sedated. There was just one challenge, as you can see, probably due to progressive decrease of sedation. Metabolism changed a lot. Adduction increased for a very low level, initial associated with depletion of 130 ml per minute to 180, 190 ml per minute. And in spite of this major change of CO2 metabolic production, you can see how end-tidal CO2 was perfectly stable during these 80 hours. And this indeed corresponded to a fantastic stability of arterial CO2, 36, 35 during 80 hours, good stability of pH, and thus performed by automatic adaptation and automatic increase of minute ventilation, mainly performed by playing with the respiratory rate. As you can see here, while the tidal volume was very stable at 7.5 ml per kilogram. So it's an example, I repeat, easy, because the lung function was good in which during 80 hours, fantastic stability in CO2 control was achieved. This is just a clinical case, but you may wonder, what does science tell us about INTELLiVENT and acute brain injury? And unfortunately, I must tell you that the field is nearly totally unexplored. Nearly totally unexplored, I found just one study. The study was performed in Russia. And it's a nice study, 12 patients, not so difficult. Even in this case, no severe underlying injury, good hemodynamic stability, sedated. It's a crossover comparison between 12 hours on pressure control and 12 hours on INTELLiVENT. As you can see, the control on average, the control arterial CO2 was exactly the same. Perfect in both cases, manual control and automatic control, with more variability, however, in the pressure control 12 hours. But what is more interesting is that while in the INTELLiVENT ASV 12 hours, nearly no intervention, less than one human intervention in the controls of ventilation was necessary. On the other side, at every time in which the researcher were sampling a blood gas, nearly every time they had to adapt the ventilator. So overshooting, undershooting, and so a lot of work. The same result can be achieved, but it is a lot of work. So my conclusion is that in theory, INTELLiVENT is information in acute brain injury, but and I hope this presentation may help maybe to stimulate research in this interesting field. Thank you very much for your attention.
Thank you very much, Giorgio, for this very nice talk, illustrating us that there is a lot of work to do regarding traumatic brain injury and the use of INTELLiVENT ASV. So we don't know anything, but your experience at least, and the experience of the study performed in Russia, probably by the Russian people, tell us that it is feasible and it is safe. And probably a statement that can be made out of the last study that the machine is better than the human being in setting the PCO2. But my first question, before I go to the question addressed by the audience, is how do you control CO2 on INTELLiVENT ASV? Practically doing, how do you do it?
Well, technically, it is entitled CO2, which is controlled, which we know that is not arterial, not arterial CO2. There is a gradient. This gradient is variable. This is the weak, of course, the weak point from the standpoint of technology. It is also true that in the condition of full control of ventilation, deep sedation, there is also more stability in the relationship between arterial CO2 and tidal CO2. And so checking and adjusting tidal CO2 with the so-called shift control that is for INTELLiVENT ASV user is well known, is relatively easier. For sure, it's easier than in ARDS and or in a disease with important lung disease.
Okay, thank you very much. So one of the questions that has been addressed by the audience is the 6 milliliter per kilogram body weight. Is this something that you use in every patient with traumatic brain injury, or maybe it leads to longer recruitment, hypercapnia, and you have to correct for that? So what is your opinion?
Okay. Well, in my opinion, well, you know, the 6 maximum is the classic indications. Indication since more than 20 years. I think that it is widely overcome by the much more relevant importance of the driving pressure. So 6 depends on the compliance. If there is lung damage, but the driving pressure is low, it's not necessarily 6. Not necessarily 6. For the, I think, very well controlled condition of passive ventilation with deep sedation, I think that in any case, the control of that space, of technical the space, is really very, very important, and this can help not to use a unnecessary high tidal volume. Then in any case, I think that using tidal volume for recruitment is not correct. Probably it's better maybe 2 centimeters more of PEEP than 2 ml per kilogram more of tidal. But this is my feeling. I don't think that there are no data that.
You mentioned PEEP as an option to recruit the lung, and one of the questions goes directly in that direction and ask, it has been shown that up to 12 centimeter of water of PEEP is safe and does not lead to an increase in cranial pressure. How would you go? How far would you go with the PEEP, and how would you set the PEEP in these patients?
Well, Marco, I would not even generalize, because I think that in some patients 12 is not so safe. It depends on the stability of their intracranial pressure. It depends on what is ongoing in the meanwhile for the control of intracranial pressure. Is a patient who is decompressed or with the derivation or not yet? It's a very important and critical evaluation about the trade-off. Of course, if oxygenation is very poor, this will be a reason for brain damage. This would be another reason for brain damage. So we cannot forget that there are times, periods in the course of a brain injury patient in which lung protection is not a priority. There are some risks. So this, I think, in general. Then there is no chance with good monitoring and very well controlled condition, you can go even higher. Of course, the risk increases as even ECMO can be done in brain injury, but then the risk of bleeding is high. If you don't use anticoagulants, is high as well. Is high. We know that it's high as well. So
another very important question has been addressed. This is regards to.
So I would say in general, I don't see well an automatic setting of PEEP in brain injury. Okay. Too complex is too complex. The choice.
Too dangerous, maybe.
Yeah.
So, but next
also
question,
because the automatic setting of PEEP has just one direction in the poor responder, increasing, while here there are limits.
Yeah. So, but my next questions, I think it has been addressed also by one of the participants, and I think it's an important question. Frequently, we observed abnormality of respiratory breathing in patients with traumatic brain injury, like chain stop breathing. How INTELLiVENT ASV does deal with this problem?
Not so well. not so well, because these are abnormal reactions of the respiratory center, and INTELLiVENT is designed to react to physiological reactions of the respiratory center. But I would say that in general, these are conditions in which, in the most acute phase, that we must control with sedation, with paralysis, and take full control of ventilation. And in that case, INTELLiVENT becomes perfect, because there is no reaction on the other side.
Okay.
My answer is that INTELLiVENT compared to other modes is not an advantage in these cases of inappropriate working of the respiratory center.
Okay. And another, I think, question which is interesting is whether would you use the same criteria for all type of brain injury, acute brain injuries? So, for example, also in for patients with out of hospital cardiac arrest and hypoxic brain damage.
I think, well, this was one question that I posed myself while preparing this presentation, because actually the indications are very general, but on the other hand, the information from the casuistics comes from different populations. There are different types of brain damage. And so I think that the very general indications that I gave can be applied to brain injury as a syndrome. Like to say ARDS, the ARDS of the brain, but ARDS as a single approach, but then this single case may require deviations. I think that at the moment there is no great information on that, but especially, for instance, the nearly crazy idea of using hypercapnia as a vasodilator to counteract a possible vasospasm is something that has been proposed just for severe subarachnoid hemorrhage with vasospasm, not in general. Not in general.
Thank you. I think one of the last questions that we have to address, that several people going a little bit in the same direction, is the monitoring ICP in these patients while you are playing with your target shift for the hypocapnia and hypercapnia treatment, if you would say like this, in this patient. How would you monitor ICP?
For me, invasively, because it's continuous, because it is continuous. It's extremely interesting checking the optic nerve ultrasound, but it's a measurement. It's not monitoring. Transcranial Doppler, not so continuous, and near infrared continuous, but the meaning of near infrared spectroscopy is always uncertain a little bit, which kind of oxygen, where it is that oxygen. Today, invasive intracerebral PaO2 seems very promising for making these very high precision games.
Okay, thank you very much. So maybe something that also has been addressed is how long would you control CO2 in these patients?
As long as it is unstable, as the ICP is unstable. First week.
How you do the weaning?
That two difficult questions. You would not generalize. I cannot answer.
So it's a challenge.
Yeah, but you know, it's like for ARDS, when to give up. For me, sometimes it's after months giving up, because there are also the very late recovery cases. So the brain is a bit more critical than the lung. But,
Okay.
I would use the criteria of as long as there is instability.
Okay, thank you very much, Giorgio. We stretched the time already a little bit more than usual, and good luck for your future. And I hand over to Caroline.
Thank you very much, Marco. Thank you.
Thank you very much, gentlemen. Yes, we have gone a little bit over time. Thank you to everyone for staying with us. We'll put the delay down to the internet connection from Italy. So thank you all for joining us. A huge thanks to the two experts for sharing their valuable knowledge with us. The link to the recording will be in your inbox as always early next week, plus a link to any additional answers. We'll be back again on April 6th. So if you're watching now, for the people that will be watching on YouTube later, if you're not already signed up for the series, you can do so now using the QR code that will be shown here very soon. And when you leave this session, may we ask that you just take a minute to answer the few short questions that appear on your screen. Thank you so much. So bye for now, and we'll see you again on April 6th. Thank you.
Bye-bye.
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 Bye-bye, everybody. Thank you for your attention.